Good morning. Great turnout. It is my pleasure to introduce the next speaker, Dr. Kenny Jump, joined us from Philadelphia, from Charlottesville, Philadelphia, over 3 years ago now. And on arrival, one of the projects I decided to tackle was the patients living in the NICU and needing continued follow-up for nutritional issues, feeding issues, who had ongoing medical needs. And in conjunction with the NICU, we expanded their NICU discharge clinic, and they've been working very hard, and they've done a really impressive job in expanding services and improving quality of care for these patients. And Dr. Jump is going to tell you all about what she's been doing.
Thank you, Dr. Quiros. Hello, good morning, everyone. As Dr. Quiros said, I'm going to be talking today about nutrition in the preterm infant after discharge. So today what I want to do is discuss some growth deficits at the time of discharge in preterm infants, talk about some shortcomings when it comes to how we monitor preterm infant growth. We're going to review how catch-up growth affects brain development and cardiometabolic health. And then we'll get to the fun part where we can talk about how the infants that leave our NICU are doing. So the WHO and the Healthy People 2020 goals say that the goal for the rate of preterm birth is less than 8.1%. So this is the 2018 preterm birth rate report card, and so it's 2017 data. And what you see is that in the U.S., only one state is actually meeting this goal, right? And that's Vermont. So how does South Carolina do? Well, we get a grade of D, which is not good. So for the third year in a row in 2017, the rate of preterm birth increased in the United States. In South Carolina, we have remained the same over the last 2 years. And Charleston County is one of 2 counties in the state that actually improved the rate of preterm birth. But what we notice, there's still significant racial disparity. So Black women in South Carolina are still 52% more likely to deliver an infant preterm compared to Hispanic, white, or Asian mothers. So in 2007, the Institute of Medicine said that preterm birth costs about $26.2 billion. So the majority of that is medical and healthcare costs, labor and delivery, but there's a significant amount of that money that is spent on early intervention services, special education services, and lost work and pay. So what does this have to do with nutrition? So preterm birth and its complications are the #1 cause of death of babies in the United States. So about 15,000 babies each year die from this. And nutrition gets a lot of play because we actually have some provision over the control of nutrition. And we know that nutrition has positive impacts on a lot of different factors. So nutrition helps build immune competence. It helps support recovery from acute and chronic illness. And it also helps to support neurodevelopmental outcomes. So a lot of the literature in the last 30 years has looked at the role of nutrition and the role of nutrition and growth in neurodevelopmental outcomes. So the gold standard for nutrition of the preterm infant has long been said to be to provide nutrients approximate to the rate of growth and composition of weight gain for a normal fetus. So essentially what we're asking the NICU to do is to grow a baby as well as they grow in utero. This is a pretty tall order to fill. So what this actually looks like is these infants are born and they go through a period of weight loss. During this period, there's early and aggressive nutrition, sometimes enteral nutrition and parenteral nutrition. And then they enter this lovely feeding and growing stage. I think we still call that now. So this stage is really characterized by the use of human milk fortification in breast milk or preterm formula. And then as these infants gain 8 weeks, what we see is that they are discharged a lot of times below the 10th percentile for fetal weight or for birth weight. So these babies are leaving the NICU with this extrauterine growth restriction. So in this graph, what you see is these arrows point to a term birth, so 40 weeks gestational age. And so for a full-term baby that's born small for gestational age, what they do is in the third trimester of pregnancy, they undergo a period of intrauterine growth restriction, and then they're born small. But the preterm baby undergoes a period of extrauterine growth restriction. So this is the period where they're actually accumulating more deficits after they're born. So what we see here is that extrauterine growth restriction. So what we classify this as being less than the 10th percentile for a specific anthropometric. And hospital discharge for most of these infants is about 40 weeks, right? So most of these infants are discharged at about term. So we're comparing these infants born preterm to a term baby, a fully grown term infant. And so here we have the percent of infants who are less than 10th percentile at discharge and their gestational age. And you can see that for babies born between 23 and 34 weeks, about 30% of them leave the hospital at less than the 10th percentile for their gestational age. Above 30% leave the hospital less than 10th percentile for their length, and about 15% leave the hospital less than 15th percentile for their head circumference. And when you look within each gestational age, so a baby born at 23 weeks who's smaller, who's already undergone a period of intrauterine growth restriction, has a harder time gaining that weight. So there's definitely a prenatal acquired deficit that grows, that they accumulate after birth too. So why does this happen? There's a lot of reasons. First, these babies can be very sick. So there's morbidities that affect their nutrition requirements, endocrinologic abnormalities, CNS damage. Babies have problems just feeding, so difficulty in suck and swallow. They're on different medications that may affect their nutrient metabolism. And it's really hard to give them all that they need in the first weeks of life, just to give them what they need. So this study looked at, what this study hypothesized is that if we're trying to feed these babies the recommended dietary intake, if we're just trying to get them to goal feeds, that we're going to fail because it's really hard to get there. So that looked at about 100 babies who were all preterm, less than 1750 grams. What you see here is number of weeks, and then kcals per kg, proteins, grams per kg, and their weekly intake. And the lower part of the graph is their cumulative deficit. So how far behind are they falling each week on that intake? The dark dots are babies that are over 31 weeks, and the clear dots or the white dots are babies that are less than 30 weeks. So they actually didn't make the goals for this study too much, right? 120 kcals per kg and 3 grams of protein per kg. That's not actually a lot of protein for these infants. About 80% of these infants were on breast milk with human milk fortifier. And you can see that over time, over the first 5 weeks of their life, they're accumulating more and more deficits. So they're falling further and further away from where their goal is. And that tends to even out at around the 5 weeks. And when you do a regression analysis for this, what they found was that 45% of the variation in their weight can be directly correlated to inadequate energy intake. So it's related to that they're not getting enough. And then another 7% is related to those babies who were born intrauterine growth restriction, so their birth weight. So these babies are lighter, smaller heads, they're shorter, but they're also fatter somehow. So we know here, so this looks at a summary of studies and compares a preterm infant to a term baby, right? A term equivalent baby. And what you see is that they weigh less, right? Their weight is about 590 grams less. But when you look at their fat-free mass, which is muscle, bone, organs, there's significantly less fat-free mass, but they're not really that much significant less fat mass. So their total percent body fat is actually higher. So they're chubbier. Even though they're lighter, they have more body fat. The problem with looking at some of these growth studies is that if there's long-term outcomes, they reflect outdated nutrition practices. So if you want to look at outcomes at 20 years, they reflect what happened a long time ago. And if you want to look at short-term outcomes, if you look at more recent nutritional practices, the outcomes aren't that long. So it's kind of hard to see how we're doing now long-term, obviously. But this is a study that has a short outcome. So when these babies are in the NICU, how long does it take them to regain their birth weight, right? That's one of the major goals that we look at for babies that are discharged, right? Even a term baby, how long does it take them to gain their birth weight? And they used two different cohorts, one from 1994 to 1995, and one from 2001 to 2009. And they divided them into appropriate birth weight cohorts. What they found was that between 1994 and 1995 and 2000, 2009, these babies are actually gaining their birth weight quicker. So in every weight grade, in every class, these babies are doing a better job gaining their birth weight. So we're doing a better job getting them there. So when we see these babies in our NICU nutrition clinic, they have a few different patterns of growth. The first is a baby that is born appropriate for gestational age and then discharged appropriate for gestational age. So just appropriate growth. And that doesn't happen too frequently. The next is a baby that was born appropriate for gestational age and then leaves the NICU small for gestational age, or less than the 10th percentile. This is that extrauterine growth restriction period. And then there's babies that are small for gestational age when they're born and leave small for gestational age. Those babies are usually the IUGR babies, or the intrauterine growth restriction babies. And then finally, babies that are born SGA and then they're discharged appropriate, so early catch-up growth, which is very rare actually. So when we look at longer at how long does it actually take these babies to catch up to their term peers, right? So this study looks at over 1,000 infants born between 1993 and 1994. And again, we're looking at infants that are less than the 10th percentile for their weight. So here at birth, so these infants represented a bunch of different gestational ages. So you can see that some of them are born less than the 10th percentile, or SGA. And then by 36 weeks, all of these infants are essentially less than the 10th percentile for their age. So these are the infants that have done that dip in the curve and are sort of coming back up. But then when you look at 18 months corrected, still 40% of these babies who are 600 grams to 1 kilo are less than the 10th percentile for their age. So they're still not caught up at about 18 months for just their weight. And this goes even further. So this study looks at about 150 babies born between 1998 and 1999. And what they're looking at is a weight Z-score change of greater than 0.67. So for those of you who are not familiar with Z-scores, a Z-score of 0 is the mean, and a Z-score of +1 is equivalent to 1 standard deviation above the mean. A Z-score of -1 is 1 standard deviation below the mean. So the significance of a Z-score of greater than 0.67 is that it crosses one of those big percentiles on the graph. So this is equivalent to like jumping from the 25th percentile to the 10th percentile. So what they looked at all these babies and their Z-score at discharge, or at term, and then 4 months, and then between 4 months and 8 months, 8 months and 20 months. And a lot of these babies actually fell on their own curve between this time period. So 8% between 40 weeks and 4 months, 28% between 4 and 8 months, and 12% between 8 and 20 months. Some of this, I think, has to do with the fact that when we make growth goals for babies, we are making the goals, and it's not necessarily where those babies want to be on the graph. So older babies, I don't think about it in a 4-month-old, but older than that, usually they're channeling to where they want to be on the growth chart. So if you had to feed a baby with the G-tube, you pick the 50th percentile for their weight for length. But that's not necessarily where that baby wants to be. And so when that G-tube comes out, or that NG-tube comes out, they do what they want to do. They do where their body wants to be. And so that might represent some of that. But even more worrisome is that at 20 months corrected age, that the mean Z-score for these babies for weight is -1.56. So the mean for these babies is mild malnutrition. So most of these babies qualify for malnutrition at this age. So to make our lives easier, we make up these rules about how much weight a baby should gain, and this is what we look at in clinic, and this baby looks good, they can go. So a preterm infant, once birth weight is regained, we use these rules that they should gain about 15 to 18 grams per kg per day. They should gain about 1 centimeter in length, and their head circumference should increase by about 0.7 centimeters per week. But this is all based on fetal growth. So this idea that a preterm infant should growth should match a fetal growth is really not substantiated by much data. It's the gold standard because that's what nature intends, but there's no data to suggest that a preterm infant who grows as well as a baby in utero grows has any better long-term outcomes. And when you go into these studies and you try to figure out what actually is happening out there in other NICUs, it gets really difficult because everyone is doing things a little bit differently. So when you look, there's a meta-analysis of 373 studies that looks just at how are we measuring growth in these infants. And 40% of these studies are using grams per kg per day, 30% are using grams per day, and 29% are using changes in Z-score. So it's hard to make generalizations about all the studies together. It's really hard to compare different studies. And the majority of studies use grams per kg per day, but then how they do the calculation is vastly different. So you don't know when the day one is or the last day is. So some people use birth as the day one and discharge as the second day, right? And grams per kg per day over that whole time period. Some of the studies just say the study started, so we'll use this day. The study ended, we'll use this day. So it's hard to know, and the rate of the rate of growth isn't the same, from 23 to 26 weeks and 30 to 32 weeks. That's a different number, and so it's hard to compare. And then what kilogram do we use? They use all different denominators for the kilogram, start and end weight, the average and exponential, a birth weight. Some people are doing it every day. So it doesn't seem like a big deal, except to me probably, but the way we calculate these things actually can change results up to 73%. So that's a big deal when you're talking about growth studies and you're talking about making curves for these babies or what the normal should be. But if you're thinking about what can alter our calculations, probably the biggest thing is getting improper heights and weights. And so anybody who has worked with me knows that this is like one of my biggest pet peeves. So we obviously should not get a length on a baby in this manner. But a baby should have a length done on a length board. Most of the time, the correct way is actually with two people, someone to hold the head at the board and someone to hold the feet and to get a length that way. The tried and true manner of using the exam table paper and drawing the lines and then smoothing it out is not very, it's not a good idea. And then this is actually my nephew. So my sister-in-law was worried about his growth. Not really recommended to weigh your baby like this either. Even if you do zero the scale, it still doesn't count. But sometimes we get weights in this hospital not to make decisions about their nutrition regimen or their growth. So the emergency room isn't going to adjust an preterm infant's feeds. Those weights in the emergency room are always higher than they are in our clinic. So you have to take that into account when you're looking at growth. If you're in Epic, you can actually click the button that says subspecialty data. And so we look, in our NICU clinic, we look at the NICU discharge weight, the NICU growth curve, and our growth curves. We take out the other ones. Our babies we use the length board. We always weigh them on the same scale. They're naked baby weights, right? They're not with their diaper and their onesie and their bib or whatever else. The other thing is that we have to correct for gestational age, and Epic also does this. So weight through 24 months, stature through 40 months, and head circumference through 18 months. So even if you do get the right weight, what the heck growth curve are you supposed to use, right? There's 27 choices in there. And so these are just a few of the growth curves that are available. Not all of them are in Epic, but these are a few of the growth curves that are available for preterm infants. So the first is the Olsen growth chart. So this is a growth chart based upon the birth weights of babies. And so it's really good for saying if a baby is AGA, SGA, LGA, appropriate for gestational age, small for gestational age, large for gestational age. But what you see is that around 36 weeks of age, it actually starts to taper out. And so that's probably a little bit related to maybe some placental insufficiency. So these babies in utero aren't growing as well, but also might be because at 38 weeks, you're much less likely to have a baby who's 44 weeks actually and falsely inflating the curve. And so gestational age is a little bit more censored out. And then the Fenton is the next growth chart. So the Fenton is this line here. And what the Fenton did is they're still using birth weights, but they smooth the curve into the WHO at 50 weeks. So they smooth that all out. So what you see here is that it's smooth, and right here at 50 weeks is where the WHO curve would go. But what the Fenton does is that it's still using birth weight. So if you have a preterm infant and you're monitoring their growth, and then you're looking at them in the Fenton, those babies haven't undergone their physiologic fluid loss. So you'll have a preterm baby that looks like they're not doing so well because the birth weight baby hasn't gone through their postnatal weight loss period. So it gets really tricky. And I like this curve because it takes your gestational age or your postmenstrual age and your grams per day, and it plots out the growth charts. And so what you can see is that around 40 weeks of age is when most of our babies are discharged from the NICU, and afterwards, about 30 grams per day is where the curves meet. So this is what we use for babies seen in this time period, this is what we use as our goal in our NICU nutrition clinic. But again, we're basing this off of curves that have some faults, so we don't really know exactly where we want these babies to be. So the current recommendation is that up to 36 weeks of gestational age, you use the Olsen. Between 36 and 50 weeks, you use the Fenton. And there's a time period between 4 to 8 weeks post-term where you can start to use the WHO and the Fenton. They overlap. But remember, if you're using the WHO, you have to correct for gestational age. And so if that wasn't enough, there are more. The Intergrowth 2015 charts are it's a project out of Oxford University, and there are about 27 different centers involved. And they're trying to find standards for pregnancy dating, maternal weight gain, fetal growth, newborn size, postnatal growth of preterm infants, what we're interested in, and then longer cognitive development at 2 years. This study doesn't have the same numbers as the Olsen study or some other studies, but what they do have is babies from different countries. And this study, on these curves, preterm infants joined the WHO at 64 weeks. The difference with this study is that they are using preterm infants that have undergone a relatively normal postnatal course. So what they're saying is that a preterm infant shouldn't be compared to a baby who is still in utero. We shouldn't be using that as our comparative group. We should be using babies that are born preterm but are doing rather well, and that should be our goal. So when you look at the intergrowth curves, what you find is that those babies that are extrauterine growth restricted on the Fenton curve or SGA on the Fenton curve, one fifth of them that are EUGR are normal, and 1/4 of them that are SGA are normal. So it does change how we interpret the curves. Again, it's great to have all these tools, but we still don't know really what is most sensitive for their long-term outcomes. And so when we talk about long-term outcomes in these infants, what we're really talking about is the head and the heart. So there's been a lot of, like I said earlier, there's been a lot of research in the last 30 years looking at the effect of nutrition on neurodevelopmental outcome. And because somatic growth and brain growth are closely intertwined, this has made people believe, like, let's just fatten these babies up, let's just get them fat, and they'll have these great neurodevelopmental outcomes. But on the other end of it, there's also this research about metabolic programming, and that these infants who perhaps they catch up too quick or they're growing too quickly in general have metabolic risk factors going on earlier in their lives. So like so many of life's great debates, we're sort of hedging between the head and the heart a little bit. And so what is the right path for these babies? This is a very large landmark study that looked at growth in the NICU and neurodevelopmental outcomes of extremely low birth weight infants. So these are infants less than 1 kg. And the question that the researchers have is that when you look at 18 to 22 months corrected age, do infants in the lowest growth velocity quartile compared to infants in the highest growth velocity quartile have a lower incidence of neurodevelopmental impairment? So for this study, neurodevelopmental impairment is hearing loss bilaterally, bilateral blindness, cerebral palsy, mental development index of less than 70, a psychomotor developmental index less than 70. So that is all neurodevelopmental. And what they found is that, really we're just interested in the first line here, is that when you compare babies in the first quartile versus the fourth quartile, babies in the first quartile have a higher odds of having CP abnormal motor developmental scores or any neurodevelopmental impairment. So this is one of those studies that sort of pushed more of the high-risk neurodevelopmental outcome clinics for NICU follow-up patients. But on the other end, if you think that babies who gain the least weight have poorer neurodevelopmental outcomes, what about babies that gain the most weight? So this is an interesting study. Again, because these patients are followed till they're 21 years old, it really reflects outdated nutrition practices. But what they wanted to see was if an increase in weight for length Z-score during infancy in these preterm infants, what was the association with determinants of cardiovascular health and type 1 diabetes at 21 years of age. So babies that gained the fastest weight for length from preterm to birth had a higher body fat percentage and waist circumference. And babies from term to 3 months who gained the highest weight for length, so weight out of proportion to length, had higher body fat, waist circumference, and cholesterol, LDL, and triglycerides. So babies in the lowest quartile don't do so well neurodevelopmentally, and babies in the highest quartile don't do so well from a cardiometabolic risk factors. So what's the trade-off? Is there any utility in fattening up these babies? I really like this study that says, okay, if you compare babies that gain BMI, so when you gain BMI, you're getting fatter than you are longer, right? And so if you look at the odds of being overweight or the odds of having an IQ of less than 85 at ages 8 and 18, all having a high BMI does is put you at risk for obesity at every time point and does not seem to have any protective effect or any long-term cognitive benefit. But if you are changing your length Z-score only, so you're growing taller between term and 4 months, it does seem to be that your risk for having an IQ less than 85 is lower. Your odds are lower. So weight gain out of proportion to length gain is probably not great in these infants. So we look a lot at their weight curves and we look at their head circumference curves and their length curves, but we really need to be looking at their weight for length curves too to make sure that they're not transcending. So we do have babies in our clinic that are at the 95th percentile weight for length. And if you look at just their weight, you might say that they're extra-uterine growth restricted, right? They're less than 10th percentile, but their length isn't catching up with them. And so those babies are at risk for cardiometabolic risk factors. So this percentile lag followed by catch-up growth and the risk for cardiovascular disease and diabetes earlier in life is now known as this X preterm phenotype. We don't really know why this happens. It might just be because we're not getting them the nutrition they need early on, right? That chart that said that over 5 weeks, they're just accumulating more and more deficits. And maybe that's some metabolic priming that just sets up their metabolism so that they're at increased risk. Or maybe we're giving them the wrong type of growth, right? Because these babies are a little fatter than other babies, despite the fact that they're smaller. Maybe just doing that is not enough. Maybe we need to think about when we're comparing them to fetal babies, we need to look at other markers, so protein accretion and other things. And finally, maybe it's just a losing battle, right? They're born premature, they are stressed out, and most of them are born after a period of intrauterine growth restriction, and we can do our best, but it's going to be really hard to affect that programming effect of preterm birth. So we don't have a lot of answers, but we know that we can help these babies. So we have some data from our NICU nutrition clinic. So like Dr. Quiroz said, this clinic was started in December 2016. We felt like the NICU at MUSC has a lot of very high-risk babies that are discharged. We were noticing that babies coming back and not doing very well in terms of their growth, a lot of readmissions, and felt that we could probably do a better job caring for them post-discharge. How they do in the hospital, their nutrition in the hospital is so very tightly regulated, and it seems we discharge them, and it's like letting your child go to college, I guess. You got to have a little faith, but we felt like we needed a little bit more contact with these babies. So any baby that is very low birth weight or extremely low birth weight is enrolled. Babies that have had a hard time feeding or growing, any baby that's discharged with a G-tube, or any other risk factor that the clinical team is worried about, they come to our NICU nutrition clinic. Most of these babies are seen, when we first started the clinic, we were able to get them in about 3 to 4 weeks, and now it's more like 4 to 5 weeks. We're pretty busy. And our research team enrolled all patients from December 2016, all new patients from 2016 to March 2018. So this is what we have. So in that time period, we saw 227 new infants. The mean gestational age of those infants was about 30 weeks. The percent African American is a 52.9%, and 72% of our babies have their primary insurance being Medicaid. So this is a high risk demographic, high sociodemographic risk babies. They are, the majority of them are low birth weight. Obviously, being very low birth weight and extreme low birth weight gets you into this clinic. So a third of our babies are born at less than 1 kg. And like I was saying before, most of them are discharged around term, so around 40 weeks. So our mean discharge age was 39 weeks. And the length of stay is around 9.5 weeks. And the mean length of stay is about 9.5 weeks in the NICU. So this is what they're prescribed when they go home. Over half of these babies are discharged from the NICU on some amount of breast milk. And after that, the vast majority are on a preterm discharge formula. So this is your NeoSure mixed to 22 calories standard. Some of them are on a partially hydrolyzed, so an Alimentum. Less of them are on an elemental Elecare formula. Some are on term, and about 22% or 50 babies were discharged with the G-tube. The majority of them are getting 24-calorie formula, so they're not supposed to be mixing it according to the instructions on the can. And less than that are discharged on maternal breast milk unfortified, 20-calorie term formula, 22-calorie just standard NeoSure. But a significant amount also go home on 27-calorie formula. So what we think they're getting at the time of discharge is not really what we find out at the first clinic. So 40% of these patients are actually not getting what they're discharged on by the time we see them. And again, this is like 4 weeks later. They're not doing what they're supposed to be doing, or they've changed it. So of those patients, the largest proportion of patients who are not receiving that regimen is because they're just mixing it wrong. This leads to about 60% of these infants being fed below calorie goal at their first clinic visit, and 16% being fed above their calorie goal. So when we look at the growth at the first visit, we took out all babies who were seen at greater than 50 weeks gestation because their growth velocity trajectory should be a little bit different. What you see is that half of our babies are going fairly well. They're meeting that 30 grams per day. And a third are, and the second half is divided among moderate growth failure or severe growth failure. We do have some babies that lose weight, so that all babies that lost weight actually were seen at over 50 weeks gestational age. So babies that lost weight did not make it to our clinic in time, which I found to be pretty interesting. And we actually do a lot in this clinic. I should say our dietitians do most of the work, actually. So most of our babies, over 90% of our babies at the first and second visit have some intervention, whether it's an increase in nutrition, a decrease in nutrition, meaning calories recommended. All babies, a significant amount get formula education. So any baby that is having a change in their regimen obviously gets formula education, and any baby that is mixing incorrectly gets formula education. We have some medication changes in our babies. Most of the time it's a weight adjust of an H2 blocker, actually. We've only put 2 babies on PPIs over in that whole period. We know the NICU tries really hard not to add PPIs to these babies, so we try to stay on board that. And then we do a little bit of constipation management, or more like infant dyschezia management, actually, because most of these babies aren't actually constipated. What we were really hoping is to see a decrease in our readmission rate. So I pulled some of the FIS data. One of our lovely FIS database people, Corinne, pulled some of this data from me. And 2015 is before we started this clinic, 2017 after. And what we looked at was any infant discharged from the neonatal or the infant DRG, so all babies that were born here and discharged and who came back within 1 year of discharge and at less than 1 year of age. And so you can see in the difference between total cases in 2015, 2017, and discharge from that DRG, and then inpatient returns in those same years. I took out all babies who were readmitted for cardiac reasons. They had a known congenital heart defect, all babies that were readmitted for planned surgeries, and then looked at just the babies less than 1.5 kgs, just the babies that we knew were referred to our clinic. And so there's not a significant difference in total number of readmissions, 27 and 25. But what we did see is that less babies seem to be getting admitted for feeding and growing issues. So, and the number of babies getting admitted for bronchiolitis remains the same. So feeding and growth in 2015, about 9 admissions, and feeding and growth in 2017, about 2. I haven't looked into those two babies, but they very well may have been referred from our clinic for admission. So just to conclude, the nutrition management of preterm infants really should be personalized to meet these babies' individual needs. So you need to take into account their gestational age, their birth weight, their medical comorbidities, and you need to think about it in both the inpatient and the immediate outpatient time period. And what we really need is some better long-term data about health and neurodevelopmental outcomes to be able to inform our growth recommendations. We use what we have now, but again, we're not sure that these are actually the appropriate ways to measure our kids. I have a few thanks. So obviously our NICU nutrition staff who is here today, and then the NICU team for giving me all the referrals. Thank you. And then Drs. Donnelly, Thomas, and Zhang helped me, or I should say, performed the majority of the data collection and have had some abstracts at national meetings related to this data. And then Corinne has helped me pull the fizz for the readmission rates. And myself and one of our NICU nutrition clinic grads will take any questions. Yeah, that's a really good question. So this clinic is a bit unusual. There's not that many of this specific type of clinic set up across the country. And so there's not really a precedent really hasn't been set. But we feel like with the number of errors we see in mixing and recommendations, that we like to see them on, at least until they're on a standard NeoSure 22 or a term formula. And then they can be discharged to their PCP. And then for the G-tube fed babies or the babies who have for oral feeding, we wind up actually referring most of them to our feeding team at 1 year of age or when they're on a standard term formula and they're really just working on feeding because they have speech there and we don't have speech with us. Sally.
Thank you, Candy. That was great. So the kids that come back to clinic that have lost weight and they come back between 4 to 6 weeks, it sounds like, or 3 to 5 weeks typically.
Yeah, all the babies that lost weight were seen about 10 weeks after they were seen. So they somehow missed their first appointment or something happened in that initial visit, yeah.
But there was a high percentage that mixed the formula incorrectly, right?
Yeah.
So is there a role for home nurse visits?
Yeah.
In between, or is that already set up?
So we haven't really thought about, some of these babies have home nursing set up for other reasons if they have a vent or they have tube feeds. But Lauren in the NICU has been working on some formula mixing videos for families and working on the mixing instructions at discharge. It's quite impressive how blasé people can be about add a little this, little oatmeal, a little this. It's very interesting.
I also think it'd be a great opportunity for incorporating telehealth.
Yeah, we have had that thought, yeah.
Ask them to mix the formula in front of you and you can give feedback.
Yeah, that's a great idea.
Do you know how frequently the parent babies mix the formula right?
So I don't know that question. I know that we were just talking about this in clinic the other week. When I was a resident, I always asked that question. Of course, I'm into this kind of thing, but and I found a few infants in my time that were mixing the standard, on the can incorrectly. So it happens. I don't think it's 40%, but it happens. Yeah. Yeah.
I know like when we discharge most people from level 2, last times around NeoSure of some amount. Is there any separation in your data for people that are doing some sort of fortified breast milk versus the oral?
So I could get that data. I haven't separated out, but what we know is that babies that are fed unfortified breast milk, they tend to have good neurodevelopmental outcomes, but they don't do very well gaining weight. So most of our babies get human milk fortifier, and then by the time they come to us, some of them are needing to transition to NeoSure fortification. But I could separate that data out. Is there something in particular you're looking at?
I'm just asking because there's an idea that maternal breast milk will be better for neurodevelopment than some formulas. And it looks like a lot of the data that you're showing had kids gaining weight, but not necessarily benefiting from the neurocognitive benefits of gaining.
Yeah.
How much of that might just be because almost all of our preterm kids are going on formula versus there's a portion of the term babies who are being breastfed.
Right. Yeah. I mean, I could pull that for you if you're interested. Yeah, Mike.
So I think all of us who have been in the NICU know that sometimes our discharge teaching isn't what it could be for a variety of reasons.
Mm-hmm.
It could be distance. It can be poor planning on the NICU staff part, and they don't take advantage when the parents are there. And sometimes I think we throw a lot of stuff at them in the last 24 hours that they're in the hospital. So it'd be interesting to know how we can parse that out, so that we can decide. So there are some parents that are there all the time, and they probably do well. That 60% that are doing it right. I bet there's some difference between their time with the baby, with the charge, and I think it would be interesting to if that split those groups out, somehow parse those out. What happens in the, let's say we're going to do 40% and 60% in the week before discharge, or something,
Right. We just had a mom in clinic yesterday who said, I said, who else are you following up with? Who else are you seeing? And she's like, I don't know. And she knew that she had a whole bunch of appointments, but she didn't know at all what they were for. And she said, it just all happened so quick. Like, I don't know. Discharge was just like, not chaotic, but it was a lot. And she said, I asked if she had a baby that was a little bit fussy. And I said, is this how this baby was in the NICU? She's like, I really wasn't there that much to know. So I think that's happening a lot. Yeah. I mean, the babies are there for a long time and parents are doing their best, but some of these moms would rather have time home with the baby when they get home than, miss. So it's a hard.
or they have other kids at home.
Right. Yeah. There's a lot of competing things. Yeah.
A lot of obstacles.
Yeah. Great. All right. Thanks, everyone.